Welcome back to Dr. Twyman's Ask Me Anything. Coming back to you every week, helping you reduce your risk of having a heart attack and stroke. So I hope you guys are having a great week so far. I'm finally out of vitamin D winter in St. Louis as of a couple days ago. Doesn't feel like it. It's still like 11 degrees here. It's going to be like 2 degrees tomorrow. So I'm going to escape back, get a little bit further south in a couple days, soak up some sun, build up the solar callus, build up the redux, and head back to St. Louis next week, and I'll be back by next Monday. So no worries, I'll be back as usual. So a lot of great questions tonight. It's also on calcium scores, asking about statins, asking about what my exercise routine is. So happy to answer all these questions, and we'll jump in. First question up tonight. Their APOB looks LDL-C target for, what is the target for a 54-year-old man with a CAC of 34, so a CT coronary calcium score, irrespective of soft plaque burden in the coronaries. So with a calcium score, you don't know what the soft plaque burden is. That's the challenge. It can be anywhere between 75% and 2/3 of the plaque still could be soft, and that's what you're really trying to treat. So if your calcium score is over 0, you want to figure out why your endothelium got damaged and what you can do to reduce the risk of developing further plaque. So typically my target would generally be an APOB less than 70, and the aggressive target would be under 55, which is the 5th percentile. And so depending where you're starting at determines if you're going to need more than one agent to get you to goal. All right, second up question tonight. What's their diet should be after a quadruple bypass? All right, that's a good question. The greatest majority of the data really falls on a Mediterranean type of template. So, optimal omega-3 levels through seafood, monounsaturated fats through olive oil, lots of green leafy vegetables to get the nitrates. That's probably why the Mediterranean diet has such an effect. So that's a good template to start. But I always have 3 big questions when patients start working with me. It's going to be, what is your maternal haplotype? That is essentially a thing that if you'll know essentially what type of mitochondria that you have. Those are your engines. That's going to determine what kind of fuel sources you're more optimized for. I want to know what your ideal body mass is going to be, because that determines your protein goals. You generally need at least 90 grams of protein a day, but optimally is a gram of protein per pound of ideal body weight. And then I'm looking at your omega-3 to omega-6 ratio, and generally want that greater than 0.25. The last thing is circadian biology rules all. So eating a seasonally appropriate diet, eating from sun up to sundown, and don't eat when it's dark. Next question up. Should you repeat a CT coronary calcium score test? If so, how often? Great question. So a CT coronary calcium score test is basically a non-invasive way to look at, do you have hard plaque in your coronary arteries? Your calcium score should be 0 forever. It often is not, but you want to delay it to the latest decade that you can before it comes positive. So generally speaking, it's a good test after the age of 40, often before 40, unless you have a strong family history of early heart attack strokes or you have familial hyperlipidemia. Generally, a calcium score test can be 0 and not really add to the risk stratification. So if you're really concerned under 40, you may want to consider CT coronary angiogram so that you can also look at the soft plaque. But that being said, if your calcium score is 0, generally we consider repeating it 3 to 5 years. After that point, if your calcium score is above 0, I generally do not recommend repeating it, because often many of the therapies used to treat plaque are going to cause the soft plaques to become hard, and often the calcium score test will go up, particularly if a statin is added to the regimen. But I do get asked, can you see calcium score tests go down? I have seen them go down, but that's not necessarily the goal. All right, so someone wants to know, what's my exercise regimen? I guess hold me accountable and keep asking me. That way I'll have to keep up the gains, essentially, that I'm trying to get this year. So the 4 pillars of optimizing health, exercise, nutrition, stress management, sleep. Exercise is always my weak link. I just get out of habit of doing what I need to do. I know better, obviously. But right now, doing a combination of resistance training with X3 bars at home, and then once a week doing ARX at BioFit in St. Louis, The ARX is a adaptive resistance exercise machine. It's basically hydraulics, which you're fighting against, both concentric and eccentric. It wipes you out after one set of each muscle group, so you can really only do it once a week. Just wrapped up a Peloton ride, so do greatest majority of my Zone 2 training on the Peloton, and starting to do a little bit more Zone 5, so just got my heart rate up to, let's see, peak heart rate was 170 tonight, so about 86% of my maximal heart rate. Generally only do that once a week. And then when the weather's a little bit better, I will be outside, usually walking. I may start adding back some rucksacks early in the morning. So I'll let you know if I change up anything in that. Also, I do once a week, I do some bone strengthening with OsteoStrong. All right, question about, is there any criticism of statins that I find compelling? It's a very good question. As I often start off, statins are tools. Not everybody is a candidate for them, but those that are, your goal is to reduce your risk of having another heart attack or stroke. Those are the main people that tend to benefit, is the people for secondary prevention. So if you've already had stents in your coronary arteries, you've had a heart attack, stroke, you've had bypass surgery, carotid endarterectomy, FIM-POP bypass, you're high risk to have those events again, particularly if they don't optimize your endothelial function, repair your glycocalyx, keep your oxidative stress and inflammation low. If you just throw lipid-lowering therapies at those people, they're very likely to have symptoms at some point in the future, leading to potentially more cardiovascular events. But that being said, the criticisms are there. Anything that you put into your system, there's a risk-benefit ratio. The major risk for the statins is muscle symptoms, muscle pain, muscle weakness. I've never personally seen a case of rhabdomyolysis where the muscles actually die from statins. I definitely saw many cases of rhabdomyolysis when I was an internist in the Navy. I took care of many recruits from Parris Island in July in 110-degree temperatures who had significant rhabdomyolysis with creatine kinases of 10, 20, 30,000. So I've never seen that with the statin. That's always the most feared about complication. I've definitely seen patients who have symptoms enough that it affects their quality of life or their exercise, and they just can't tolerate statins. Typically, a little bit more with atorvastatin, Lipitor, and rosuvastatin. It's not as common to have that. Pravastatin's even less. And the least likely is really called pitavastatin. But if people can't tolerate statins, there's 3 other classes of medicines that help reduce cardiovascular events. Those include ezetimibe, the PCSK9 inhibitors, those are the injectables, and then the oral medication Nexletol. So if people can't tolerate statins, there's more options. The other criticism is that we can raise blood sugar. Have I seen that? Yes. Has it taken somebody who had normal glucose and made them frank diabetic with an A1C of 6.7? No, never seen that. It usually just raises a few points, but if it's a big issue, you just try a different medication. Next question up tonight. Does red light therapy treat or help idiopathic premature ventricular contractions? Probably indirectly. If it helps lower inflammation, you'd have to have a decent sized panel to really absorb deeper than kind of skin level to have direct cardiac effects, but you can treat the blood supply with panels. You can use torches. This is my Celio well torch. Got red, infrared, and both. So you can put that over anything that hurts. And then one of my favorite kind of portable ones is my Solbase Bright, battery powered, so DC electric. Don't have EMFs off this thing, so you can put it on your chest, thyroid, shoulder, whatever hurts. I don't usually say that the cheapest brands, you want to get a brand that works. It's that combination of the time that you put the device on your skin or stand in front of the device. Ideally, it's skin contact if you can get a device that does that. It's the power density, or the irradiance is the other term for that. So it's essentially how many photons of light are coming out of that device. And then it's the colors, what wavelengths of light. It's like cooking a turkey. You can't cook a turkey in 1 second in the microwave. So you need the proper light, you need the proper intensity, and you need the proper duration. So if you're looking for some potential resources, my website, drtwyman.com, does have some links to some of the companies that I either have their brands in my office or my personal collection of red light therapies, or I've spoken to the inventors or owners of the companies and know that the specs of the devices do what they say they can do. All right, next question up tonight. My CT coronary calcium score says below 1. Is this still a risk factor, or is it the same as 0? So I get this question often. I always say that the calcium score that I like the least is a calcium score of 1. Because, well, life isn't fair. If your calcium score is 1, your risk of a vascular event triples compared to somebody who has a calcium score of 0. So a calcium score of 0, ballpark your 10-year risk of having a heart attack or stroke is a little over 1%. If your calcium score is 1 to 100, your risk is a little over 4%. And once you start getting over a calcium score of 400, you're 15% risk of having a heart attack in 10 years. And if your calcium score is over 1,000, it's well over 25%. So the higher the calcium score, the higher the plaque volume, the more risk. The risk tracks with the volume of plaque. So if your calcium score is anything but 0, you want to figure out what's driving the glycocalyx to be disrupted, the endothelial dysfunction, so basically the protective layer of the arteries has been damaged in some way. The lipoproteins are getting retained in your intima. That is essentially like having a splinter. You're causing inflammation and swelling in the arterial lining, and then the plaque starts building up as more cholesterol gets deposited into the artery walls. As white blood cells gobble up the lipoproteins, kind of like Pac-Man. So that's what I would do if your calcium score is above 0. All right, and last pre-submitted question. Any advice why their diastolic pressure is always high in the morning and okay at night? It will sort of depend on age. It will depend on, are you on any medications already to treat blood pressure? Are you insulin resistant? There's going to be a lot of things that drive that, so it's hard to know for sure. But the gold standard to figure this out is to wear a 24-hour ambulatory blood pressure monitor. There's also devices now that are kind of like a Holter monitor patch. We have those in our office at Apollo Cardiology. That device is called the BioBeat. It's basically a sticker that sits on your chest and non-invasively measures your blood pressure for 24 hours. So then you get to see what is your average blood pressure throughout the 24 hours. You get to see your blood pressure load. So each quartile, like how many blood pressures are greater than 70 diastolic, how many are greater than 80, how many greater than 90. And then the trend overnight. Your blood pressure should be dropping or dipping at least 10 to 15% while you sleep. If your blood pressure is not dipping while you sleep, that is a much higher risk factor of, you have sleep apnea, you have some other issue where your blood pressure is high while you sleep when your body really should be recovering. The risk of stroke and heart attack is highest early in the morning as the blood pressure starts to surge, as cortisol starts to increase. So it could be potentially a cortisol issue as well. But in my world, I always look at nitric oxide pathways because if those aren't optimized, that's the low-hanging fruit. So you can get salivary test strips to see if you have good nitric oxide pathways through the oral pathway. And there's different biomarkers you can look at, including ADMA, urine microalbumin creatinine ratio, uric acid, homocysteine. Those are some of the good ones right off the top of the bat that if they're high, that may be driving high diastolic pressures. The other thing I didn't mention is it's your environment. Where are you when these things are being monitored? One blood pressure is at home and the other's at work or out in, at the gym or something. It could just be the environment that you're in. I don't know what your EMF exposure is where you're taking this. If you have a smart meter on the other side of the wall, you're sitting by your Wi-Fi router, smart TV, computers, maybe that might be driving up the pressures. All right. Well, I think we got through the pre-submitted ones tonight. Those are excellent. As always, thank you guys for your good questions. I will have this video up on my YouTube channel within a week. It takes me a little bit to run it through AI, get it all transcribed, and upload it. But that's where these will be housed in addition to the kind of archives on Instagram. So my YouTube channel is just drtwyman.tv, or if you go over to YouTube, just search for my name up there, Twyman. All right, and some questions popping up in the comments. Is there any way to reverse reoccurring atrial fibrillation? And could mold exposure trigger it? So the second answer is possibly, but people who are very sensitive to mold are also generally sensitive to non-native EMFs. And then reversing reoccurring AFib is often due to oxidative stress and inflammation. So a comprehensive blood work panel will tell you how much oxidative stress and inflammation you have. I've also seen that microvascular disease have an effect on that. So if you have low nitric oxide, confirmed with an abnormal pulse wave velocity test, something like a max pulse. If you have an endopat scan available, if you have low nitric oxide on an endopat scan, that sometimes can drive it. Uncontrolled sleep apnea can drive it. Alcohol, thyroid dysfunction. Have not seen caffeine really be the big driver. It's usually alcohol. So possible, but would need more details. I don't primarily work with people with heart rhythm issues. I definitely have experience with them though. So if your local doctors can't get to the root cause of it, you could always reach out to my office and see if we're available for at least an educational consult to point you in the right direction further than some generalities I can do on Instagram. All right, so somebody's asking, do I have any thoughts on peptides for cardiac health or regeneration? These are my thoughts. I've never prescribed them. I've never taken one. I've gone to the last 3 American Academy of Anti-Aging Medicine conferences in Las Vegas, the Longevity Fest. 3 years ago, the rage was peptides. 2 years ago, the FDA cracked down on peptides in the compounding pharmacies, and it was like a blackout. Nobody talked about them. This year, a lot more kind of knowledge was kind of releasing about them. But I still say they're definitely gray zone because there's not a lot of data behind them. The people who compound them have anecdotal reports, honestly, but there's no great studies behind them. And the second thing is you're adding an exogenous compound to your system. You're asking the mitochondria to do something that it wasn't aware of what's going on in your environment. So you never know with some of these things what you're going to downregulate. So I would be very hesitant to consider peptides unless you work with somebody who knows a lot what they're doing. It can show you the research. All right. Well, I think I wrapped it all up in 20 minutes or less, so maybe that'll be my new motto. So it's always generally 6 to 6:30 Central Time, Mondays. But if the questions are answered, I'll let you guys have an early evening. If anything pops up in the interim, always happy to answer them week to week. Just drop them in my DMs. Otherwise, every Monday I put up a little story in the morning on my board, and you can always ask the questions there. So I think I had one other question, so I'll answer this, then I'll let you guys go. So I think it says I'll have to kind of rephrase this. So something like, is there a 5-point to-do list for minimized cardiovascular issues and ED issues in your 40s? So I don't know if the ED is endothelial dysfunction or erectile dysfunction, but they're basically cousins. So 5 things. I would say get a CT coronary calcium score or a clearly CT angiogram and know what you're dealing with. Look for the plaque. Biomarkers are important, but the plaque is the big thing that you need to address. More plaque, more risk of cardiovascular events, and that's what you're trying to reduce. Second is endothelial dysfunction, or ED for short. It starts with the glycocalyx getting disrupted. It's a protective gel coat in the arteries. Things that improve nitric oxide, it's exercise, it's green leafy vegetables, it's UVA sunlight, and then looking into the biomarkers for, okay, what might be driving the endothelial dysfunction. So looking at endothelial dysfunction, very important. Looking at oxidative stress and inflammation, that'd be 3. Number 4, looking at lipoproteins, having Lp(a) or lipoprotein A checked at least once if you haven't. high LPA is associated with doubling your risk of a vascular event compared to somebody who has normal LPA. And fifth, probably would do something that tracks your sleep. Sleep is when your mitochondria optimize. If you're not sleeping well, start there. All right. Very good question, guys. All right. Hope you have a great week. And I'm going to go get a quick sun run in here on the midweek. And I'll be back next Monday for you. So take care.